Welcome back. Ready to talk about the remainder of the bacteria? Remember that we are now done with all of the oxidase positive gram negative bacilli. Making progress, pat yourself on the back. And now we're ready for the only remaining groups of the standard garden variety bacteria, which would all be oxidase negative, which remember means that they do not have cytochrome C oxidase. Now, if you don't have cytochrome C oxidase, either you are an anaerobe, as Bacteroides is, or if you are a facultative anaerobe using oxygen as long as it's available and then switching over to fermentation, then you have to have another terminal electron acceptor. And so what the Enterobacteriaceae do as a family is they use nitrate as their final electron acceptor, and in so doing they reduce it to nitrite. Okay, now you may not have put that together, but realize that is why we check urine for nitrite. If there is nitrite in the urine, it means that there is a member of this family causing problems in the urinary tract. Now, this is the only family that you need to know, and I know it's a family because of that suffix, ACEAE. It's a rather large group of organisms that are divided first into those who are lactose fermenters versus those who are non-fermenters of lactose. Remember, the ones who don't ferment will make colorless colonies on the two differential media, eos and methylene blue or McConkey's. The ones who are fermenters will make colored colonies. Now, I believe I gave you the memory tool before. Citrobacter, Enterobacter, Escherichia, and Klebsiella should be in here as well. That, notice it spells Ceek, C-E-E-K, and that should imply to you that that's the first half of the mnemonic, Ceek. The second half is S-H and Y and P and S. So the whole thing is Ceek ships. Now the second half, the first part of the second half, the SHY portion, Shigella and Yersinia are the ones who don't do anything. And I have a rather not ladylike memory tool here. Remember that when you have Shigella, you are doing nothing but, and then I'll let you fill in the blanks. Okay? So Shigella does nothing but, and that takes it Yersinia also. P and S don't ferment, but they do at least move and produce H2S gas. So Proteus and Salmonella are the two that fit into that category. Now, as we look at the unifying characteristics of the organisms in this group, realize that they all ferment glucose, they're all catalase positive, they use nitrate as their terminal electron acceptor, which I just explained to you. They all have endotoxin, and some of them, quite a few actually, make exotoxins as well. We designate them within their groups by analyzing surface molecules that they have. So O is the abbreviation for envelope, H is the flagellar antigen, K is the capsular antigen, and VI is the capsule of Salmonella. Now, if you notice, that's really the only one that is from the English. VI stands for virulence. So the virulence attribute of Salmonella is the capsule. In the case of the others, it's a little bit more difficult. So what I do is I draw an O on my page, which sort of looks like the margin of a gram-negative bacillus. And then I take my pen and draw an H through that O, and that sort of looks like flagella sticking off of the surface of the organism. And then finally, if I take my pen and I draw little K's all over the outer surface, not only do those look like K's, but they look like V's depending on how you turn your head. So the two capsular antigens are K and VI. All right. Now, starting out with Escherichia, which is a very important member of the group, remember that this one is virtually everywhere, human and animal colonic flora, so you can give it to yourself. It can be passed from mother to child during delivery. It can be fecal-oral contamination of food. Our most common outbreaks come from the enterohemorrhagic strains, or EHECs, and they come from cattle feces. Remember that this is the #1 cause of UTI overall and the #2 cause of neonatal meningitis and septicemia. So as we think about what we're looking for here, when we talk about E. coli UTI, the presenting complaint would be dysuria. They would need to tell me that they find 10 to the 5th colony forming units of a nitrite positive organism in urine. And remember, that number is important because it allows you to distinguish between the contamination of a clean catch and an actual infection. In this case, it's been transmitted from your normal flora. The important pathogenic features are adherence with pili, motility, ability to move against the flow of urine, and many of these guys are beta hemolytic, which of course will contribute to bloody or red urine. Treat with fluoroquinolones or sulfonamides. When we're talking about neonatal meningitis, of course, it would be within 2 weeks of birth, an infant with fever and irritability, gram-negative rod in the CSF or on blood culture. The mechanism is that maternal fecal flora will contaminate, and of course, anytime I have something moving from one location to another, I'm going to have the advantage of endotoxin making blood vessels leaky and facilitating that movement. Additionally, the K1 capsular type is typically associated with this presentation, so a clear-cut pathogenic mechanism. Treat with ceftriaxone. If we're talking about a patient who is on an indwelling catheter or is on cytotoxic drugs that may allow the organisms in the normal flora to escape, then this would be a septicemic condition, high fever and confusion, and it is endotoxin which causes the majority of the problems in that case. Treat with fluoroquinolones or third-generation cephalosporins. As we move into the E. coli gastroenteritis, remember this is one of only 2 places where I suggest to you that you need to know abbreviations within the micro. As a general rule, the USMLE will avoid abbreviations unless they're absolutely given. DNA and RNA, of course, will be abbreviated rather than spelled out. But in most cases, they're concerned that an abbreviation might not be in common usage in your country of origin or your medical school. And so they are very painstaking about spelling out an abbreviated use the first time around. And then after that, in the question, they will perhaps use that abbreviation again. In the case of the gastroenteritis caused by E. coli, they will expect you to know these abbreviations. And the reason is that their favorite question on the subject is going to be, how does the organism cause its pathogenesis? So if you think about the fact that the abbreviation tells you that fact, then it's pretty obvious that they're not going to spell it out because it would give you the answer to the question that they want to ask. So enterohemorrhagic E. coli shouldn't surprise you that it's going to be a bloody diarrhea with a name like that. But realize this is the one exception to the rule that if I have blood in the stool, I will also have fever and pus. Because remember, the mechanism here is that of a protein inhibiting toxin. Protein synthesis is shut down by the virotoxin or the Shiga toxin. They're the same thing. Remember, it is through shutting off the 60S ribosomal subunit that I get cellular death, which causes the hemorrhage into the bowel. But that's not an inflammatory condition. Thus, no fever, no pus. And because that's such an unusual outlier, that's a really important distinction for you to make mentally. Notice also, antibiotics are contraindicated as they may increase the risk of development of hemolytic uremic syndrome. This is also the only one, the serotype that we have in the United States that is most common is O157H7, and that organism makes colorless colonies on sorbitol MacConkey's agar. So it doesn't ferment sorbitol. Make sure you realize that's an important diagnostic criterion. EIEC is indeed an inflammatory diarrhea. So it does invade the bowel wall, causing blood and pus and fever. Remember, it's typically children in a developing world, so not so common in the United States. ETEC is the most common cause of diarrhea in travelers. So the T in that case stands for toxigenic. And remember, the toxin ribosylates G sub S, causing that watery diarrhea. The stable toxin stimulates guanylate cyclase. And those abbreviations refer to whether or not it is labile in temperature or not, or stable in higher temperature. The labile toxin, the stable toxin. Now, that one is a very, very common one. So I personally would argue that the ones that they're most likely to ask you about are EHEC and ETEC, just because of the numbers of cases. But we also have EAEC, which stands for enteroaggregative, and enteropathogenic E. coli, which less common except in developing countries. So unless they give you some sort of a clue that this is an immigrant infant, etc., I would not diagnose these in the United States. However, enteroaggregative is the one that is a biofilm producer, and enteropathogenic is the one that has bundle-forming pili that will promote effacement lesions in the bowel. All right. Onward from there, we have Klebsiella, an important agent of both septicemia and bronchopneumonia. So remember, this one comes from the colon and is also found in the upper respiratory tract, and the patient typically gives it to themselves. When we're talking about the cough and fever, realize we're talking about a typical bronchopneumonia with a thick gelatinous sputum that's sometimes described as looking like currant jelly. Okay, currant jelly, in case you're not aware of it, is actually a very nice thing to put on toast in the morning. So I've always found that explanation somewhat distasteful, but it does get across the idea bright and jelly-like. It's because of the production of blood high up in the bronchial tree at the bifurcation, and as a result of that, you're getting little time for it to oxidize before it's coughed out. The capsule interferes with phagocytosis, has pili which mediate an attachment, and if it gets into the blood, of course, endotoxin is a major problem for spread. Dysuria, if I have a urinary tract infection, Realize typically with Klebsiella, it happens following some sort of nosocomial contamination of catheters. So I would culture the urine and find the classic description of the family. The pathogenesis is the mechanical introduction of the catheter. And then as we talk about the septicemic condition, fever and confusion would be the presentation in patients who are immunocompromised and have had invasion of their IV lines. So cancer patients who have had escape of organisms from the gut, also possible. Anytime I get a gram-negative into the blood, it becomes a problem of endotoxin communicating directly with the endothelium. Now, notice over in my treatment column that I have the same comment for all of the Klebsiella groups, regardless of what the presentation is. This is a tremendously resistant group. And so realize, although I would start with fluoroquinolones or third-generation cephalosporins with or without an aminoglycoside, realize I need to set up my sensitivity testing, and it's really very likely that I will be caused to change my choice within a short period of time when the lab results come back. So tremendous amounts of drug resistance in the gram-negative rods overall, but Klebsiella is hugely resistant in many cases. Shigella, so now we've left the fermenters of lactose. Notice I did not discuss Citrobacter or Enterobacter because frankly I think they are minor organisms and not worth spending too much time on. Now as we move into the non-lactose fermenting groups, remember first of all we have the ones who do nothing, Shigella being the poster child of that. So when we think about Shigella, human-to-human transmission, we don't have Shigella dysentery in the United States, but in the United States, our most common species is Shigella sonii, and remember, it does not make that Shiga toxin. So sort of by definition, our cases are less severe than those in the rest of the world. Fecal oral contamination is the means of acquisition. Remember, of all the things we'll talk about, this is the one that is most acid resistant. Okay, so 1 to 10 organisms are the infectious dose required, which means I don't have to have very poor sanitation in order to have exposure. There is no carrier state in this case. Now, before we leave this topic, let me just do a brief review for you when we're talking about infectious doses, because remember, it does run hand in hand with how much poor sanitation you'd have to have, or how much damage to the ability of the stomach to make acid, like a person with a subtotal gastrectomy. So remember that Vibrio won the prize of having the highest infectious dose. It hates acid, and therefore we don't see Vibrio unless there's significant lack of sanitation. Okay? Next, we would have E. coli and Salmonella being two that take around 10 to the 5th to make you sick. Then we would have Campylobacter, which we talked before in the curved gram-negative oxidase-positive rods. Campylobacter takes about 500 organisms to make you ill, and here we are with Shigella with 1 to 10, okay? So notice, as I think about how much an organism likes acid or doesn't like acid, how much it's likely to be mentioned in the context of a poor sanitary condition versus not necessary to mention that. Those sorts of things factor into how they will construct the case history that you'll be looking at. Now, Shigella, of course, is a bloody diarrhea. Normally, we see this in the United States in either infant or adult daycare situations. What I'm saying to you is that it doesn't take very much exposure. And so if I have a situation where persons are responsible for managing diapers of either adults or infants, it means that even with good hand washing and sanitation, it's entirely possible to get exposure. It is an invader. The Shiga toxin also directly kills cells by acting on the 6DS ribosomal subunit. So I will have fever and blood and pus. It is generally self-limiting, but in the case of very severe infections, trimethoprim sulfamethoxazole can be used to shorten symptoms. And I should stress again, remember, our most common strains don't make the Shiga toxin. So that would only pertain if they gave you a person from an area outside of the United States. Yersinia, our second one that does nothing. We can divide this into two broad categories. Yersinia pseudotuberculosis and enterocolitica are zoonotic agents in northern climates, and so typically they're acquired from unpasteurized dairy or pork products. Yersinia pestis, remember, is the agent of the Black Death or plague, also a zoonotic, transmitted either from rodents via the bite of fleas or human to human in the pneumonic form. Now, surprisingly to some, this is endemic in the United States in the desert Southwest. So we do have a few cases every year in the United States without any travel being necessary. When we talk about the first two, pseudotuberculosis and enterocolitica, they are generally agents of pseudoappendicitis in children. So the child would present with fever and abdominal pain. Notice the issue of enrichment of the culture at 25 degrees centigrade. This is one of those organisms that likes cooler temperatures. And remember, we've already talked about that being true of listeria, which is also associated with delicatessen foods. We talked about it with Mycobacterium leprae as far as the areas of the skin, but remember, we don't culture Mycobacterium leprae. It is a facultative intracellular, so remember a granulomatous inflammatory response. APC1, TH1, back to APC1, requiring interferon gamma. In the immunocompromised, I use fluoroquinolones or third-generation cephalosporins, but truly the better technique is to prevent spread with pasteurization and properly cooking pork and other foods. Now, one of the clues that is often given toward the lack of pasteurization, and this is not a specific commentary just for Yersinia, but could equally as well pass for listeria, is remember that if they mention something about goat milk or goat cheeses, remember, some of you who have been educated or grown up outside of the United States would realize that goats actually make fairly nice pets. And sometimes the pet goat is milked and cheese or butter are made. And so if that material is not pasteurized, it can be a source of some of these organisms. So if they were to mention dairy products coming from goats, they might be hinting at the fact that it could perhaps not be pasteurized. All right, now, when we talk about plague, remember, this is going to be an issue of conjunctivitis and fever and confusion from high temperature. The bubonic plague is a rapid increase in fever and the description of buboes, which are lymph nodes, which simply hemorrhage onto the skin near the site where the flea bit. Okay? Now, remember, this one is extremely transmissible. It is our last one on the bioweapon watch list. Remember, Brucella and Francisella and Yersinia are all extremely easily transmissible and potentially transmitted accidentally in the laboratory. This is a fatal disease before the advent of antibiotics, so need to rapidly treat aminoglycosides and a strong 72-hour quarantine after the starting of therapy. Now, other than that, if the patient lives long enough to have it spread via the blood and into the lung, realize that this can be directly transmitted to another human in that way, or it can be produced from the initial onset of the bubonic form. But the distinction is a much more rapid progression to death. Takes a couple days only to kill you after acquiring the pneumonic form. These are facultative intracellulars all throughout the genus. Remember, this is our second coagulase positive organism, if you recall. Our first one was Staph aureus. But the role of coagulase here is in making the flea a good vector because it clogs up the mouth parts of the flea. And so the flea has the sense of starving to death and bites repeatedly, continuously discharging these bacilli into the bite wound. Obviously, endotoxin is important in the gram-negatives. The envelope antigen protects against phagocytosis, and the military has a vaccine that they have not been asking on the exam, but of course, as we worry about things being potential bioweapons, we need to have some sort of preparedness for that possibility. So our final group within the family Enterobacteriaceae are our non-lactose fermenting ones, but now who are motile and produce H2S gas. So the last two letters, P and S, Proteus and Salmonella, fit into that category. Proteus comes from the colon and the environment. You can either give it to yourself or can get it from water and soil. It is a fairly common agent of urinary tract infection, so dysuria would be the presenting symptom. And the pH of the urine on the dipstick would be elevated, and it would be urease positive, which ends up being the most important of the pathogenic features, in fact. Because what urease does, of course, if you recall from Helicobacter, which is another one of our urease positive organisms, what urease does is raise the local pH in an area. And so what happens when the urinary pH is raised is that I have predisposition to a classic type of kidney stone, which is described as either struvite or staghorn, depending on whether you're talking about the chemical composition or the shape, okay? They may also mention in the clue that there is an unusual ammonia-like smell to the urine, and of course, the entire genus would have nitrite positive urine. The motility is all over the place. It swarms, which basically means it does not make discrete colonies on agar, and that's because it's totally covered with flagella, okay? Endotoxin, when it gets into the blood, can contribute to the danger of the septicemias. I treat with fluoroquinolones or third-generation cephalosporins or trimethoprim sulfamethoxazole. Okay, while I'm here, let me give you a little memory tool for my urease positive organisms. I use the mnemonic PUNCH. I think you can see what P is for here, Proteus. U is for urea plasma, which is another agent of UTI and also another cause of struvite or staghorn calculi. N is for nocardia, and I did not mention it with nocardia because we don't know of a role in pathogenesis in that case. C is for cryptococcus, which is the urease positive yeast. Again, we don't know the role in pathogenesis. And H, we have talked about already, that is Helicobacter. The role of urease in that case is to allow the organism to create a little cloud of neutral pH around itself and thus invade the gastric mucosa. So our last member of the Enterobacteriaceae is a very large group within the Salmonella, and there has been quite a bit of taxonomic reorganization, and I am not going to recommend that you have all of it memorized. There are about 2,000 serovars, which are distinguished by their antigens, as we discussed before, but remember that there are really only two important clinical distinctions. So we either have the non-typhoidal salmonella, which are transmitted from poultry and reptile pets, or we have the typhoidal salmonella that are responsible for typhoid fever. So if you know the typhoidal versus the non-typhoidal ones, you're going to be good enough. 1,999 subtypes that are non-typhoidal, and only one name that you need to know that is typhoidal. Now, Salmonella enterica typhi has a carrier state, persons who are infected with a pathogen but have no overt signs of disease. All of these guys, as I said, have a very high infectious dose. And as I said, the only important clinical distinction is between the typhoidal and not. The non-typhoidal salmonella are the #1 cause of osteomyelitis in my sickle cell patients, as we mentioned before as we were going through Staph aureus. Now, in the case of my pathogenesis, if we're talking about typhoidal salmonella, remember it's going to have to be a traveler to an endemic area. We do not have typhoid fever in the United States, but that person would not present with diarrhea, but instead with fever and abdominal pain. So notice at 1 week, the organism has invaded the bowel and is being carried by macrophages throughout the lymphatics. So I can find blood cultures positive during this first week and a faint pink rash on the abdomen described as rose spots. By 3 weeks, the organism has returned through the biliary tree into the bowel, and so then the stool cultures would be positive. So the capsule is important in protecting against phagocytosis. We classify all the salmonella on the basis of their antigens on their surface. And remember, with a carrier state, we have to track down and treat the carriers. Ceftriaxone, cefixime, ciprofloxacin, all will work. Now, notice this is an enterocolitis. I did not mention diarrhea, although certainly in the later stages, I may have that be a diagnostic clue. But it's an inflammation of the lymphatic organs in the abdominal area. So much more known for fever and abdominal pain than it is for diarrhea. And often, in fact, the constipation will be the presenting symptom. There are vaccines available in special use cases for travelers. They have not been asking those special use vaccines routinely on your exam. Now, the non-typhoidal salmonella, remember, are going to be gastroenteritis agents. I will see diarrhea. And they come from poultry, so the mention of some sort of contaminated eggs or poultry products. Presentation is nausea, vomiting, fever, and diarrhea. And although it invades, it doesn't go very deeply, so it's not going to be a frankly bloody diarrhea. The mechanism of causing the diarrhea is secondary to induction of prostaglandin synthesis, which then secondarily increases cyclic AMP. And supportive therapy only is recommended because antibiotics seem to increase the possibility of it transitioning into a carrier state. In my sickle cell patients with bone pain and fever, this is osteomyelitis. Remember, typically adolescents at the point of having sickle cell trait are functionally asplenic, and so the normal flora can escape into the blood from tiny little infarcts, spread to the bone, and cause the problem. So anytime I have an organism with a capsule, it can spread in the blood more easily if the spleen is gone. Ceftriaxone, drug of choice in that case. Our last gram-negative rod is Bacteroides. Remember, this is the #1 anaerobe in your colon, and it's aerotolerant, meaning that it has catalase, which allows it to survive in mixed cultures. You give it to yourself when there are problems, any sort of bowel trauma or surgery or damage, cytotoxic drugs, and because it has a very prominent capsule, what we typically see after one of those traumatic incidents is the fact that we develop abscesses that must be drained after the fact. So presentation of abdominal pain, nausea, vomiting, and fever sort of sounds like most everything else we've been talking here for a while, but it causes peritonitis, abscess, or septicemia in a patient with a history of some sort of surgery or trauma. Remember that I'm going to have to use techniques of anaerobic transport to get it to the lab to culture. And that is something that you have to have a hand in. Normally, it would be your laboratory personnel who would do that for you, but your sample taking can make a difference. The endotoxin of Bacteroides is less toxic than the endotoxin of the other gram-negatives because it's missing a portion of lipid A. So that's one of several reasons why your normal flora actually protect you from more harmful presentations due to the fact that they're competing with organisms that would have a normal endotoxin. Normally, it's treated presumptively. Any sort of known scheduled surgery is going to be pre-treated with metronidazole or cefoxitin or clindamycin before any sort of surgery. But obviously, people do not schedule themselves for car accidents and other types of spontaneous trauma that can occur. So that's a good place to stop for now. Our only remaining bacteria are the unusual ones, which we will come back to and treat in our next session.